Good morning, friends. I'm glad to bring greetings to you all from India. Today, I'll be talking to you about challenges we face in screening and early detection of breast cancer in India, which perhaps holds true for other countries as well, such as ours. Let us look this up first. What is the difference between screening and early detection? And as you can see, screening is when the cells are precancerous and symptoms are yet to develop. So, a targeted population undergoes screening, whereas early detection is picking up cancer cases at a stage when coordinating diagnosis with therapy could result in a cure. Talking of issues and challenges we face, it is all about patient leakage. Here is a study from Telangana province of India where three major cancers, the cervical, oral and breast cancers were being screened as per government policies. And this was what was observed. 8,39,550 subjects were screened. 8,396 screened positive, of which 1,805 reached a proper diagnosis. 1,624 amongst them chose to go for therapy. Only 1,380 completed the treatment. After completion of treatment, only 552 subjects came back for follow-ups. So it goes to say that even if we succeed in screening 5% of our population and assume 1% to screen positive, 57% would not seek diagnostic confirmation and 10% will not even initiate treatment. Post initiation, 15% will default treatment and 60% get lost to follow-up. Now, about breast cancer, which is the foremost female cancer in the country, like in the globe. Globocon 2020 estimated 2.3 million new cases as global prevalence. 14% of all cancers in women in India are breast cancers. Overall mortality is 10.6%. What is alarming here? It is the fact that India is going to have an exponential increase in number of cases with more and more percentage of cases getting diagnosed late, impacting the survival rates which will continue to decline. And what are the consequences of this? We need to probe into the alarm being raised by these figures. Low survival in India has been attributed to lack of awareness about screening programs, low socioeconomical status, low education status, and lack of adequate diagnostic and treatment facilities. Higher mortality is also due to late stage at diagnosis. Now let us see what policy factors need alteration to combat this. India has limited cancer registries. Healthcare access amongst the rural women is very poor. Healthcare providers are very few and uniformity in the treatment facilities is lacking in district levels as well as medical colleges in the periphery. Patient travel time and the cost factor in availing services are big negative factors. To top this up, there are factors like a woman's family reputation, social fears, and embarrassment. Also, their old-fashioned convictions which make them seek respite in indigenous products and faith healing systems, thereby delaying their presentations. A recent systematic review spoke volumes on the low rates of use of screening modalities in India. 27.3% females practice breast self-examination, 16.71% get a clinical breast examination done, and only 7.12% undergo mammographic screening. One study from urban India tested the awareness status amongst females. It revealed the serious lack of awareness existing amongst them. For example, only 3.74% could correlate axillary lumps with breast cancer. 12.75% thought that skin changes over breast were also significant. 33.34% thought early menopause had an effect on breast cancer, while only 28.57% women attributed late menopause and oral contraceptives with breast cancer. The NFHS, or the National Family Health Survey in India, reported that only 10% women undergo systematic breast screening As you can see the map of India here, the blue areas are sparse and scattered, representing 10 to 40% screening areas. Rest are all pink, representing below 10% screening rates. Let us now talk of breast self-examination. WHO does not recommend mass screening by breast self-examination even for Indian population. A rural Indian study found 28.2% anxiety and 5.5% depression cases in women who were subjected to breast self-examination. Global trials have failed to show mortality reduction with this modality. However, breast self examination for Indians does improve the physician visits and acceptability to additional investigations, which could be beneficial for us. Coming to mammography, it is the most widely used screening method for breast cancers with definite benefits in 5-year survival rates up to 85 to 99% due to early detection. Even mortality rates have likewise shown reduction by 21% in 60 to 69 years age group. The problems with mammography in India, however, are its cost and availability. It needs expensive machinery along with trained personnel and effective quality control. Mass screening, hence, is difficult. Clinical breast examination. It is a viable and promising alternative to mammography in India. It is low cost, technically simple, women friendly, and a touch sensitive procedure. The discomfort and hazards of radiation can be avoided. Only it needs appropriate training along with experience for the performers, and the margin of false negatives has to be accounted for. Now let us have a look at some of the CBE evidences from India. A cluster RCT trial carried out in Mumbai for efficacy of clinical breast examination for over 20 years showed that a reduction of 15% in breast cancer mortality was there compared to controls. In women aged over 50 years, it was even more, that was 30%. Another mass clinical breast examination campaign in the province of Kerala in southern India deserves a mention too. In 2018, 9,942 women were screened with CBE in 101 awareness camps over 66 days. Results showed 868, that is 8.73% women had findings and 258 were advised mammograms. 16 women out of these were confirmed to have breast cancer, that is 1.61 per thousand women. Mean age of these women was 44.46 years. 82.5% were screened for the first time. Inference of the study was that clinical breast examination favors early detection and clinical breast examination campaigns can improve screening behaviors and breast awareness amongst women. Now, this was about the various studies and documented evidences on the subject. I would now like to take you all through 3 small scale studies we conducted on screening and early detection at our level. The first one was an observational study on around 600 women employed in our own institution. This study included faculty, students, nursing officers, and other female employees. We checked their awareness about breast cancer and found that 90% faculty, 50% students, 75% nursing officers, and 20% of other workers had a fairly good knowledge on this subject, as was evident from the MCQs used to test them. On being asked how many actually practiced self-breast examination, we were surprised to know that only 10% of faculty, 2% of students, 7% of nursing officers, and only 1% of other employees actually practiced it. Only 5% of faculty, 0% of students, 2% nursing staff, and 0% of other employees had a voluntary clinical breast examination screening ever done in their lifetimes. 5% of faculty, 0% students, 0.2% nursing officers, and 1% other employees had ever been investigated for breast issues. It actually meant that they came to the hospital for getting clinical breast examination or an investigative modality used for the breast issues when they had symptoms, not otherwise. By the end, we found 26% women had benign breast diseases. We had 2 cases of breast cancers detected through this study. The second study was on opportunistic screening of attendees of patients visiting our outpatients department. We all know pretty well that opportunistic screening is no screening at all. However, we had a different motto in our minds, and that was to increase awareness and provide breast health education to those women visiting our outpatients section. We planned to screen 382 participants and 255 of them, that is only 66.74% women, accepted the screening examination. The rest refused. Few important points emerged from our attempts. Even women who had breast cancers in their family were not forthcoming to accept screening. Convincing women who had a lump detected on CBE for further investigations was not very easy. The reluctance was irrespective of their financial and educational status. Our inference was that the denial has some unknown factors underplaying and they need to be probed into. The third study was carried forth after the above two in collaboration with few NGOs. And in this, we went down to personal hands-on coaching of peripheral doctors and rural healthcare workers who were familiar with women under their jurisdiction in their vicinity. 200 healthcare workers were trained using videos, stylistic models, followed by live volunteers, and finally the patients over a period of 3 months in a supervised manner. After this, they were sent back to their provinces with their assorted tasks. The acceptability rates were very high. 95 to 97% coverage was achieved in just 3 months. Roughly 5,000 women could be screened in 3 months. Having one-to-one talk and door-to-door service, personal touch could be administered and each of the women could be cajoled into further investigations. Schools, colleges, religious congregations, and common meeting places were arranged for them. Outreach camps were organized for educating and conducting CBEs. We found this to be really helpful as they could clear their personal doubts and their relatives could also be explained the details. So, the solutions can be forthcoming. We need a mass scale targeting of women. We need systems in place, educating them on breast health. We need to show them positive outcomes of early detection, encourage screening, alleviate fears through skits, songs, media support, talks, and one-to-one contacts. Survivor group clubs with motivational speeches would help too. The other major problem is of finances. Using welfare societies, governmental health policies, they can be convinced to initiate, complete, and also follow up for their post-treatment sessions. A word regarding mammography buses. Few places in India have tried this, but the problems faced are many. Cases crop up between visits. There's a false sense of security which creeps in after the first screening. People fear the associated pain. Also, the ominous diagnosis on that machine becomes scary for some. They start viewing the mammobuses as ominous white elephants. It does not hold a bright prospect, at least for present rural India, where awareness is still lacking. Now, this depicts a model. This model is being used these days using peripheral healthcare workers for a resource stratified care pathway. To summarize, the issues and challenges in India for screening and early detection of breast cancers are many. However, early detection is essential for dealing with the breast cancer survival problems in India. We still need CBE as the primary tool for our women. Protocol based models and personal touch techniques can offer solutions. Thank you.